Hey guys, we're going to talk about this article that came out in the JAMA, which is the Journal of the American Medical Association. So I went to medical school, I went to dental school, so I get this journal. It's funny because a dental article came out in there. So they did a review article on common oral lesions. So we're going to get into that. The main three things that they came up with to talk about are dry mouth or xerostomia, candidiasis, which is like a fungal infection of the mouth, right? And canker sores or Aphthous ulcers. If you're a dentist or a patient, these can be really hard to treat. And these are three major things. And so we're going to take the good stuff from this article, some of my experience, in my practice over 17 years, and talk about how to manage and treat these things. So whether you're a doctor or a patient, or you've had these things before, know people with these issues, this is going to benefit you, I think, and it's interesting for whoever, or you're just into fringe topics, I guess. So let's get into it. So basically, we are talking about fungal infections, canker sores, and dry mouth.
Huck to and spit on that thing. You get me?
So LFG. Actually, I always forget.
LFG. Mother.
Okay, so this article in the March 2024 JAMA talks about these common oral lesions. And what they did was they took articles from 2012 all the way to 2023. So this is very recent stuff. They found 83 articles that met their criteria, and they went over them, and they got their recommendations based off that. I'm also going to sprinkle in some of my own experience to do this. So let's just get into it. Dry mouth. It's been in the news a little bit. Saliva actually has been more in the news. But dry mouth, they reviewed 26 studies and found that dry mouth, or xerostomia essentially, which is the feeling of dry mouth, has like a 23% prevalence. So 23% of the population may suffer from this at some point. So what is freaking spit? What is saliva? It's really water. 99% of saliva is actually water. And there's glycoproteins and ions mixed in as well. And people also call it xerostomia. And what xerostomia really is when a patient tells you, or you tell a doctor, hey, I have dry mouth, my mouth feels dry. That's xerostomia. It's a subjective feeling. It's basically, yeah, I have dry mouth, but it doesn't tell you the reason, right? So you could have dry mouth because of a medication. You could have dry mouth because your glands don't function well. We call it salivary gland hypofunction. So basically, xerostomia itself is just a subjective feeling. So what does saliva do? We know one of the things it can do, but it's a defense mechanism, right? So there's immunoglobulins in there, salivary IgA. You learn that very early on in college and even dental medical school and so forth. It's a protection, repairs oral tissues. It helps with digestion. Like 10 years ago in my office, we did this game. You're supposed to eat 6 saltine crackers in a row really quickly with nothing to drink. It sounds super easy. I was like, 6 crackers? That's no big deal. Without anything to drink, that's fine. You just start putting them in your mouth and start chewing 6 of them. I couldn't swallow it. I had to drink something. Like, it's that hard, So imagine having to just eat regular food and then feel like you always need some water or something to wash it down with so you can actually swallow. That's what we're talking about. That's not normal usually. I mean, don't eat 6 saltines and that's fine. But if you're eating regular food and you always need something to wash it down with, you probably have dry mouth, right? So that's what we're talking about here. And so saliva aids in digestion, softens food up and that sort of thing. Helps with taste, helps with tooth remineralization. Can I say that? So yeah, if you have less saliva, you might have more tooth decay, right? So what can dry mouth lead to? So we'll get into this, but it can lead to fungal infections. 11% of patients with dry mouth have fungal infections. Dental caries or cavities, we know that. Dysphagia, what is that? You need water to swallow. It's hard to swallow, dysphagia. The global prevalence, like I said before, is around 23%. One of the things patients complain about the most is like bad breath. So halitosis, right? So dry mouth can cause bad breath. So yeah, it's kind of a big deal. Dry mouth is associated with age. So generally this happens in patients over 60, so older patients. But get this, so many medications can cause it. Hypertension medications can cause this. So anyone on a blood pressure pill, right, which is super common, right? Labetalol, metoprolol, Cinepril, whatever you're on, right? Anticholinergics. People take these now for sweating. Like they're taking, these medications to help with hyperhidrosis. Antihistamines can cause it, antipsychotics, sedatives, and antidepressants, which a lot of people are on. So all these medications by themselves can have a side effect of dry mouth. Hey, Hammock. The guy you got to get down. All right. See, these things aren't recorded or edited heavily, so sometimes you get cats. The other thing is, even if you're not on one of those medications, if you're on like more than 3 medications of whatever, those medications by themselves or together can cause dry mouth. So over 3 medications. Sjogren's syndrome, which is basically your body attacking itself. So your body is sending lymphocytes to the exocrine glands and attacking them. So that can cause it. What's the workup? So you see a patient in your office. How do you work this up? So you want to get a medical history, a dental history, and a medication history. And you want to do a physical exam, right? So feel their glands, their parotid, their submandibular area, check for asymmetries, things like that. See if there's a physical issue you can feel. Tumor, cyst, anything like that. Blockage, right? Stone. So how do you treat dry mouth? Water. We're talking like they're recommending over 2 liters of water a day. I know I have a lot of global listeners, and we're in America. I don't know if we all know what liters actually is, but just so we all understand, it's like a half gallon. So like a half gallon of water a day, which is a lot. I don't even drink that much at all. I should, but I don't. How else do you treat dry mouth? Sugar-free stuff, candies, gum, things with xylitol. Just keep it away from your pets, right? Glycerol, triester sprays, electrolyte sprays, that sort of thing for dry mouth. Pilocarpine and cevilamine. These are medications that can help. They're basically muscarinic agonists that can help with dry mouth. If you don't know how to prescribe these, I'll put the prescriptions up on the screen as well, so you have information there. 1% malic acid and sialagogue type sprays. It's another way to treat dry mouth. Sjogren's symptoms. So Sjogren's disease. I'm going to move this cat out of the way. Hold on one second. Come on, Hammy. All right, you got to sit still, buddy, if you want to be in this. All right. So there's mild and severe Sjogren's syndrome. So you're basically, like I said, Sjogren's, your body's attacking itself. How do you treat mild Sjogren's symptoms? You can, the same thing, sugar-free candies. You can give those medications I mentioned, before. Severe Sjogren's syndrome. The problem with this is, at this point, your glands are screwed, right? So it doesn't matter how much medication you give, the glands aren't going to secrete any more saliva. So you're really stuck with just the sprays. Right. So that's how you manage that. So that's dry mouth. I've been performing these procedures since 2010. My first case was with Nobel implants, and I continue to use them today. You can see and feel the transformative difference this makes in a patient's life. Get a second, third opinion, and then ask them, what system they're using, and just do your due diligence. So now let's get into fungal infections of the mouth, or oral candidiasis. So everyone pretty much has fungus in their mouth. It doesn't mean you have a yeast infection in your mouth or candle infection or anything like that. It's an opportunistic infection. So what does that mean? It needs an environment to make it overgrow. So you have an imbalance in your mouth of some sort, chemical, anything like that. And that's when these things can happen. So it's a commensal organism that basically overtakes due to imbalance in the oral cavity. Right. Not only does it just kind of attach itself to your tongue, your cheeks, or whatever, it's a biofilm that can penetrate inside the tissue. The symptoms of an oral fungal infection include like a salty or, get this, a metallic taste. So patients tell you, hey, I got this metallic taste. I actually saw a patient a couple weeks ago. Her main complaint on the referral was a metallic taste. So what does that trigger in my head? Oh, let's check for fungal infections. Because this patient has a metallic taste, you want to look for blood, you want to look for things like that. You don't always have to see the white lesions. You can have a fungal infection with a red denuded area. It doesn't have to be a white yeast-looking thing. Little red denution on the tongue typically can be a fungal infection, right? So it's not always a white plaque. So yeah, that's the thing. Metallic taste is a key with fungal infections generally. A burning sensation in your mouth, raw surfaces, things like that. Patients with those little cracked corners of the lips. If you see people with their corners of the lips that are cracked, which is angular cheilitis, that's actually usually a fungal infection, right? You can treat that, and I'll tell you how. Lesions under your dentures, you have ill-fitting dentures, denture stomatitis, and so forth, right? So candidiasis, when do you usually see these fungal infections? Immunocompromised patients, right? We know this. Patients taking steroids, always ask patients if they're on a steroid inhaler because that can predispose them to oral fungal infections. HIV, AIDS, salivary gland hypofunction, like we talked about before, lichen planus, which is an autoimmune disease, and dentures, bad fitting dentures, and so forth. So how do you treat it? And I'll put this up on the screen, but basically my go-to has been the clotrimazole troches. So it's basically 5 little candies or lozenges that you kind of have the patient suck on and dissolve throughout the day while they're awake. And you want to treat it for about 2 weeks, so that's my go-to usually. I think it's well tolerated. They don't taste that bad. And it's easy. It's better than like a rinsing thing or a gel that you got to coat in there. There's my conazole, tablets. A natural way to help with this is probiotics, so that's also cool. The go-to for a lot of people is just nystatin oral suspension. I don't really like that. I don't think it's well tolerated by patients, so they don't use it as well as they should. So those little cracks in the corner of your mouth, how do you treat those? Angular cheilitis, right? I'll put this up on the screen. So it's an antifungal cream mixed with a steroid. It's a nystatin cream and so forth. So I'll put all this up on the screen, how to treat that. So if you have a patient with that and, that comes in, this is basically how you treat it. All right, let's get to the last thing, recurrent aphthous stomatitis, canker sores, right? That's another way to say canker sores. It's basically the most common oral lesion, believe it or not. You'll see this in teens, mid-teens, late teens, early 20s. I just saw a patient 2 weeks ago for a wisdom tooth consult. And, I looked in his mouth. He's got ulcers everywhere. And I talked to him like, I get these from time to time. So they're pretty common in kids. I say kids, but teens, right? So basically ages 10 to 19 even. So as young as 10 can get these. Round and oval ulcers with a gray fibrin layer and a red ring or erythematous ring around it. There's 3 forms of canker sores or oral aphthous stomatitis. There's a minor, major, and herpetiform. The minor is the most common. It's 80% of these cases. Basically, the lesions are less than a centimeter. And the way you tell these apart is generally oral ulcers, like canker sores, they're not going to really be on the gums. They're going to be inside the cheeks. They're going to be in the non-gum areas. So they can be on the tongue, but they're usually on the inside cheeks, that thin tissue. That's where they like to be, for the most part, under your lip, right? Then there's the major form, about 10% or 15%. The major form. These lesions are over a centimeter, so these are really large ulcers, and they take a lot longer to heal. The least common form is the herpetiform. They call it herpetiform because it kind of looks like herpes. But again, these are really tiny little ulcers, but they're not herpes. They're actually on the cheeks, right? They're not on the gums. Herpes generally is going to be on the gums. Now, what are the causes of canker sores? Nutritional is a big one. We say folic acid, B12, ferritin, vitamin D. And diseases, celiac disease, Behçet's syndrome, which you don't want, trust me, irritable bowel disease, or IBD, iron deficiency anemia, HIV, AIDS, and so forth. A big cause you'll find online and maybe even on TikTok or whatever is SLS, or sodium lauryl sulfate in toothpaste. Believe it or not, they've done some studies on this, and they found that sodium lauryl sulfate in toothpaste is a trigger for a lot of people for oral ulcers. So if you're getting these ulcers, or your kid is, look at the toothpaste you're using. Try to find some without the SLS in it. And try that for about a month and see if that makes any difference. A lot of people find that that's a huge thing, so avoid the sodium lauryl sulfate in your toothpaste and mouthwash type things. For oral ulcers, there's these 4 studies, these 4 double-blind trials that were done on SLS, and they found that limiting or stopping the SLS toothpaste, decreased the ulcers in a lot of patients. That was, statistically significant. So yeah, look for that. If anything, if you get anything out of this, check for that. How do you evaluate a patient with canker sores, right? So you want to get a family history, a medical history, look at their medications, like methotrexate is a big one. Systemic symptoms like GI, weight loss, things like that, especially in older patients over 40. I say older, but yeah, patients over 40, with these ulcers, look for other symptoms because it could be a GI issue, right? Like IBD, like we talked about. How do you treat them? All right, so topical steroids like triamcinolone, laser therapy even has been advocated. Steroids or short courses of steroids help, Medrol dose packs, things like that. Colchicine, azathioprine, dapsone, and thalidomide, pentoxyphyline. So I'll put all these up on the screen for you. But basically, there's a lot of different remedies or treatments for this. The best steroid, though, for oral canker sores, I found is dexamethasone elixir. And I'll put the dose on the screen for you. Or clobetasol is another one. But these are the 2 I found that work the best for bigger cases, essentially. And for ulcers that, you treat, they just keep coming back. Prednisone, 20 to 40 milligrams a day for 7 days and taper it. That's another heavy hitter, for the worst cases, basically. Natural cures, cumin, honey, probiotics, right? So you can definitely go into those, especially if you get these quite a bit. That'll be super helpful. And lastly, I'm just going to talk about canker sores versus herpes. And just in the past month, hey, Meg, you got to get down, buddy. Come on, hold on. Let's get the cat out of the way first. There we go. All right, I'm almost done. So canker sores versus herpes. What is what? I literally, in preparing for this, I had a patient a month ago came in with, like I said before, a wisdom tooth consult. He's got canker sores. They're on his cheeks. They're on the inside of his lips. I just saw another patient a week ago, lesions all over, and I'll show you pictures of these lesions all over the gums, herpes, HSV, right? So that's the main difference. Herpes lesions, HSV lesions are going to be on the attached tissues like the gums, like this. Canker sores, Aphthous ulcers, usually on the non-keratinized tissues like this. So I hope you guys got something out of that and you met my brand new kitty, Himmick. Say hello. Hello. He says hey. But sorry about the pause in the episodes. We are back.